Mark Reilly. I'm going to stop my share.
Okay. So you've just seen some beautiful, beautiful osteotomies from the last two presenters. That's going to stop for the next 10 minutes. Um, and you know, for trauma surgeons, you will certainly be faced with dealing with femoral neck non-unions and malunions. I'm asked to speak on Pertrochanteric malunions and non-unions, which does pose some differences for sure to the femoral neck. For one thing, they're quite uncommon. Non-unions of the intertrochanteric femur is estimated to only be about 1% to 2%. And the ones that don't heal are oftentimes neglected or infected as a complication. Malunion, it's interesting, some authors will say malunion is also an uncommon finding. And I think others believe that the malunion rate after intertrochanteric femur fracture is extremely high. In fact, nearly universal. It's so uncommon for an intertrochanteric femur fracture to heal in a perfectly anatomic position. But we can definitely say that symptomatic malunion is quite uncommon. So what's the typical deformity? Well, obviously there's usually some varus, but not always. Typically the femoral shaft is medialized and the leg is shortened. And then there's also the likelihood that there may be some malrotation. That malrotation is usually excessive anaversion, and that's most likely from the patient being positioned on a fracture table, the leg internally rotated to make the AP appearance of the fluoroscopy better. And in fact, what that does is to create an excessive anaversion and fixing the patient with a malrotation. I'm not going to spend a lot of time talking about rotation at all because that's the subject of our next talk from Dr. Miranda. The patients will usually present with a limp. They'll be complaining of gluteal dysfunction and weakness from the high riding greater trochanter, resulting in a Trendelenburg gait. They'll tell you they have a limb length inequality on the malunited or non-united side, and they will typically have pain, particularly if they have a non-union, but they can also get abductor-related fatigue pain from the gluteal dysfunction. They can get trochanteric impingement from the abnormal varus position of the proximal femur, and they may have hardware-related pain over sites of prominent protruded or failed hardware. And of course, long-term, we can't ignore the effect on the knee or the spine, which is that persistent medialization of the femoral shaft will overload the lateral compartment of the knee, leading to symptomatic lateral knee pain and potentially valgus deformity. And the long-term effects of leg length discrepancy can have effects on the lumbar facets and obliquity of the pelvis. So why does it happen? Well, you know, it happens for some reasons we can't help. Intertrochanteric femur fractures typically happen in elderly patients with a lot of comorbidities. Their bone quality is quite poor. We can blame it on the patient and say they didn't protect their weight bearing, but of course we shouldn't be asking them to. But those are things that we can't control. But so much of the reason that we see pertrochanteric malunions and non-unions are modifiable, and that is that the reduction achieved is poor initially. The implant choice may be incorrect. The implant may be inserted incorrectly, or the surgeon may not recognize comminution posterior medially or fracture characteristics that lead to an increased rate of failure. But the thing is that it doesn't just happen in old people, it happens in young patients as well. And so if we're going to be considering an osteotomy for a pertrochanteric problem, our goals really should be to restore the patient's anatomy, to eliminate their limb length discrepancy. Moving their trochanter into a normal anatomic position will help improve their gluteal function and decrease their limp. We hope, we believe that restoring the patient's anatomy will result in relief of pain. Obviously, if there's a non-union, we want that to unite, and we certainly want our osteotomy to unite. And in fact, the osteotomy through the intertrochanteric area can help with union from both a mechanical and a biological sense. From a biological sense, we get fresh cuts that may remove some atrophic or avascular bone. And done well, an osteotomy gives us the opportunity to compress two broad surfaces under strong compression and achieve union, hopefully with minimal complications. I think it's important to tell patients that the restoration of the anatomy it's unlikely to completely eliminate their symptoms, but we have to believe that an incomplete correction or leaving persistent deformity has got to be worse than making their femur as close as possible to the shape that it was before it was injured. So why is this so uncommon? Well, it's so uncommon because it typically happens more to elderly patients, as we said, with poor bone quality or pre-existing hip arthritis, or hip arthritis secondary to cutout of an implant or failure of the implant. There's significant bone loss in the soft bone from the previous implants. And so surgeons will oftentimes suggest or select arthroplasty. And I think it's not unreasonable for sure in this patient population. It's a quicker and easier operation with less morbidity than putting the patient through an osteotomy and then having them heal. But we still see these problems in young patients where an arthroplasty is not a great option. And so if we don't know the role of an osteotomy in these situations, then it becomes something that is a lost art and is not thought of. In fact, it's interesting that that Hardy Weber over 30 years ago bemoaned the fact that the art of the intertrochanteric osteotomy was being lost. And if it was being lost then, it's probably even closer to being lost 30 years later, unless surgeons continue to talk about it and teach its advantages. So how is our planning different from that for a femoral neck non-union or an atraumatic proximal femoral deformity? Well, it's not really that different, except that we have a sagittal plane deformity quite commonly that we really have to address. So the coronal plane deformity, we can utilize the techniques that we've seen so nicely discussed, templating from the contralateral side to determine our angular correction. But it's really important to, in these injuries, to identify the sagittal plane deformity and include that in our plan for correction as well. And of course, we recognize that it's not two deformities, one in the coronal and one in the sagittal plane. It's a single deformity that happens to be non-orthogonal to the two planes that we have x-rays in. So that's the angular deformity, but then we have the axial deformity, both length and rotation. As I said, I'm not going to talk about rotation, but the shortening. So similar to the femoral neck, our techniques for reestablishing length through the osteotomy is either the amount of wedge that we take, so the width of the wedge. If we go all the way across the femur, we don't achieve as much lengthening as if we take a small wedge, where we get much more lengthening, but in exchange for less bone contact. And we also have the possibility, if our osteotomy is oblique, to lengthen and lateralize lengthen the leg by lateralizing the shaft along the obliquity. And of course, the more oblique that osteotomy is to the shaft, the more length we'll get for the same amount of shaft lateralization. But we don't want to overdo the shaft lateralization, or we'll throw the patient's mechanical axis through the medial knee. So the osteotomy, it can be combined with a greater trochanteric osteotomy. The green line there on the plane is not the trochanteric osteotomy. That's an axial line for alignment. But it's infrequently necessary because in the intertrochanteric malunion or non-union, the relationship between the head and the trochanter is often maintained, or it's acceptable. And so oftentimes we can work with the proximal femur as a single piece. And in fact, sometimes the osteotomy for intertrochanteric femur fractures or malunions is actually easier than planning that for femoral neck fractures. The fixation has to include compression, whether you get it from mismatch compression, offset compression, as Roger told us, or whether you get it from axial compression through an articulated tensioning device. We have limited surfaces of bone. The intertrochanteric osteotomy for this situation, we have the possibility for large surface areas, but still without compression, we're likely to run into problems with our osteotomy healing. We want a fixed angle, absolute stability construct. And we don't typically need to bone graft large defects, but any bone that's left over can be added to the shoulder of the osteotomy to help for healing in these situations. So coronal plane deformity, how can we plan for that? Well, I never knew how to plan for that and how to translate that to the bone, but a technique that I've been using is the wire technique that Keith described. And so you can see that on the left, this isn't an intertrochanteric malunion, but it's just a description. You can see on the left, I've got wires that are set up for my wedge resection. On the right, you can see there are two cranial wires. One is more cranial than the other. That's for a 10-degree correction in the sagittal plane. So I didn't have the lateral view, but if you were to look at those two wires on the lateral plane, they would be at 10 degrees to the orientation of the proximal fragment. And so now if I use those wires for my osteotomy, I can both get my coronal plane correction that I planned for, as well as getting now a sagittal plane correction that'll allow me to correct what is typically a flexion deformity in these injuries. And I don't know how how other surgeons do that, and of course would love to learn. Complications, thankfully, are pretty rare. One is avulsion of the greater trochanter. I think we've probably all seen that. As Keith showed in his case, you can have a fracture or crushing between the blade insertion site and your osteotomy as you compress, particularly in older patients where the bone quality is soft. Non-union of the osteotomy is really, thankfully, quite uncommon. This area of the bone heals quite vigorously, and so that's not something we typically run into when the surgery is done well, but we do see it sometimes, and of course, other surgical complications. So if we look at some cases, these are cases from my first 10 years in practice. And the reason that I selected those is because there were technical errors. And I think that certainly for me, I learned most by critically looking at what I should have done differently, what I should have done better, and performing the osteotomies in a different way. So this was a young woman, a 39-year-old female with this intertrochanteric femur fracture malunion. She's around a year from injury. Her main complaint was hip pain and inability to flex her hip. She also had lateral pain over her implant, which was quite prominent. She was relatively thin. She had a leg length discrepancy of about 2 centimeters and a quite significant gait. She's 39 years old and she's very unhappy with this situation. So we need to quantify and understand our deformity, right? And so got about 13 degrees of flexion on the lateral view and 16 degrees of varus. And so my thought was she's about 3 centimeters short, excuse me. And she's around 10 degrees of excessive aneversion. Not terrible, but something that has to be considered. So in the operative plan, I wanted to perform a closing wedge osteotomy that would correct her angular deformity and also then allow for a correction of the flexion deformity. So the rotation being only 10 degrees, my plan was to ignore it and reassess. And so what happened intraoperatively? Well, I took my planned wedge out and closed it down and was happy with the alignment there. In inserted my implant, and just as you would expect, I ended up lining the front of the bone up because I incompletely and inadequately planned the osteotomy, I ended up with a posterior gap. So now I have two surfaces that I can't stably compress because I'm really riding on a very small knife edge of anterior bone, and I've got a posterior defect. And rather than shorten the patient more to achieve better surfaces to compress, I thought she was young. I could stabilize the osteotomy. I placed a neutralization screw across it and used my wedge to bone graft the posterior gap. That's her, a little bit post-operatively there. And by 6 months, it's gone on to fail. So what did I not do? I didn't have a compressible surface. I did not achieve a stable construct. And so now I've got you can see the plate bending into varus, the screws are failing. And now I have a non-union of my intertrochanteric osteotomy that I caused. So an unusual problem, not something easy to read about. I reach out to my colleagues and my friends, and I think it was Keith Mayo who told me that sometimes the second time around on an osteotomy, you now don't have clean surfaces, you'll have irregular surfaces because of the non-union, and now it will achieve compression. And so I went back, removed the blade, inserted a new, actually the same blade, but same dimensions, but in the same path. And all I did was use the articulated tensioning device and provide axial compression of this. And now the compression would hold. There was no bone graft added. I didn't do anything except compress. And about 3 months later, you can see she's completely filled that in and healed her osteotomy. And then had her hardware taken out at some point in the while later. So what should I have done differently? I should have planned better. I should have understood the coronal plane deformity. I should have ended up with compressible surfaces and not relied on a neutralizing implant with bone graft to heal an osteotomy. So lesson learned. This is a 28-year-old female presented with this x-ray. She is about 9 months after injury. She had an intertrochanteric femur fracture, which was probably through either an aneurysmal or unicameral bone cyst, resulting in such a severe collapse. Her main complaint was pain with abduction, in that she really couldn't stand up straight without her trochanter impinging on her pelvis. She was 4.5 centimeters short, extremely unhappy. So options here. Well, you could distalize her trochanter or perform a relative neck lengthening, but you're leaving her with no offset, with a very medialized femoral shaft. And in a 28-year-old, she's going to run into knee problems down the road. Plus, she's still 4.5 centimeters short. So I didn't think that that was a good option for her. And again, reaching out to my friends and colleagues, they pointed out the similarity to the deformity that you see in Perthes, and had opportunities to do double absolute neck lengthening osteotomies for Perthes disease. And so it seemed like, although this was a traumatic situation, it seemed like this would be something that would be possible. So we obviously want to try and get as much of the length back as possible. We want to improve the offset between the femoral head and the shaft. That's going to require lateralizing her shaft, lengthening her along a long oblique osteotomy, repositioning her trochanter, and replacing the bone graft with allograft. So osteotomy looked something like this, with trying to restore her neck length by lateralizing her through the obliquity. There was also a small closing wedge to increase the valgus at her fracture site, and then to bring her trochanter down and fill the resultant space with bone graft. It looked like that post-operatively, and you can see that very large allograft between the femoral head and the trochanter and the intact shaft. And so you might think that that would not unite. here she is post-operatively. As I think if you get advice from people about your cases, you need to show them the post-operative x-rays. And so I had the opportunity to show the x-ray to Jeff Maston, to Keith Mayo, and to other colleagues and friends. And everybody said, why didn't you fix the trochanter down? And yeah, so 5 months later, she's healed her osteotomy, and her trochanter escaped and broke off of the top of the blade. Totally avoidable complication on my part. So once I thought she was healed enough, a few months later, I was able to pull her blade and then bring her trochanter down and try and refix it. And she moved subsequent to this, but about 10 years after her surgery, I got a card from her saying that her hip was functioning well. She had had her hardware removed. She did not use a lift. She thought her leg lengths were very close to equal, and had no hip pain, and was very appreciative and very happy. That's a CT scan that she was able to send me, but you can see that her trochanter, after her hardware came out, still escaped. So in summary, intertrochanteric non-unions and malunions are rarely treated with osteotomy, but this situation will come up where an osteotomy is the best solution for it, and we can't always rely on arthroplasty. The principles and techniques for correction are similar to those for femoral neck osteotomies, and we have to understand and plan for all the components of the deformity, and of course maximize osteotomy surface area and compression. I just wanted to finish with one thing. It's more for me than for anybody else, but over the last month, I've had a lot of time to reflect and reflect on this topic, and how you learn something when there's not a lot available to you to read. I finished my fellowship being unaware of Bombelli's textbook and unaware of Powell's textbook. I had Schatzker's textbook to learn about intertrochanteric femur fractures, and the chapter written by Maurice Mueller. And it was the AO that allowed me to meet the surgeons that would teach me how to become a better hip surgeon. So, sorry. I've been fortunate enough to know some wonderful surgeons, and along the way, meet some additional wonderful surgeons. And very happy to call them friends. And the fact that from my laptop, I could find a case on this topic from all of them to study. And the fact that I had the chance to meet them and become friends with them, I thank the AO for. And I thank you for your time.